Hello, everyone. Welcome to our webinar today. We're so glad to have you here. On behalf of the California Labor Lab, Anaya Center of Excellence for Total Worker Health, we're so pleased to have you here. I have a few housekeeping announcements before we get started with the session today. You are going to be muted during the presentation. If you'd like to ask a question, please enter it into the online Q&A box, and we'll save time at the end of the presentation to address as many questions as possible. This presentation is being recorded and will be made available on the California Labor Lab and Center for Occupational and Environmental Health YouTube page in the next 5 business days. And all participants who logged in with their registration email for the full live presentation today will receive an email tomorrow with a link to your evaluation form. And once you've completed that evaluation form, you'll be eligible for one continuing education contact hour. Once the evaluation is completed and submitted, you'll be able to access and print your certificate. Just a note about the Total Worker Health is a registered trademark of the U.S. Department of Health and Human Services. And we receive funding as a part of the Total Worker Health program that makes these webinars possible. And the mission of the California Labor Lab is to extend the pursuit of health and safety for workers in traditional employment to those in a wide range of alternative arrangements in partnership with affected communities. And we're absolutely delighted to announce our upcoming conference. We have a 2-day virtual conference occurring on April 29th to 30th, 2025. Our theme this year is on art and labor in a gig economy. So we do hope you can join us online. This content will also be available for free for you all to register and to enjoy. A continuing education contact hour certificates are for an additional fee, but the content itself will be available to all of you live, online, free, and we hope to see you there. And with that, I'm going to pass it over to Dr. Christina Banks to introduce our speaker for today.
Thanks so much, Michelle. And I couldn't be more pleased to have Dr. Bresnik have his presentation with us today. It's an incredibly important topic, and I hope you all get as much as possible from this webinar in order to protect yourselves and your loved ones. The title of our webinar today is The Ongoing Threat and Challenges of Antimicrobial Resistance, or AMR, as people like to say for short. But first, let me give you a little bit of background for Dr. Bresnik. Dr. Bresnik has over 40 years of experience as an infectious disease physician and scientist. Dr. Bresnik has dedicated his career to the advancement of understanding, treatment, and control of infectious diseases in the United States and around the world. His areas of clinical expertise and experience include direct patient care and infectious disease management, infection control and prevention, hospital epidemiology, and antibiotic stewardship. Dr. Bresnik has also cultivated a deep and detailed knowledge of the drug development process, which includes successfully navigating the path to regulatory approval for new antimicrobial drug candidates and indications, both in the U.S. and globally. His current focus is on antimicrobial resistance, the more silent pandemic that preceded COVID-19 and will continue long after the novel coronavirus is brought under control. The unmet needs related to AMR include new antibiotic development, reimbursement strategies to make these development efforts economically viable, and antibiotic stewardship, particularly where and how it is this important drug class can be optimally utilized and controlled in both human medicine and agricultural veterinary use. And with that, I am pleased to introduce Dr. Bresnik. You have the floor.
Thank you, Christina. Thank you for that introduction, and thank you for the invitation to speak today. It is a topic that's near and dear to my heart, and I'm very passionate about the need to get the message out and continue the control and fight against antimicrobial resistance. Just to give a couple more details as to where I've been and what I've done. I was in private practice in infectious disease consulting and internal medicine at Alta Bates for nearly 20 years, and then moved on to the biopharmaceutical arena, first at Gilead for another 20 years, doing research with liposomal amphotericin B for invasive fungal infections. More recently, for the last 3 years, I've been with a small biotech startup, not a startup, they've been around for a while, F2G, which is developing a new first-in-class antifungal agent for people with unmet needs and limited treatment options. And then continued with infection control and antibiotic stewardship at Alta Bates even after I left practice. So with all that as context, let's get into the topic at hand, which is antimicrobial resistance. With me for a moment. Okay. Is my individual slides
So right now
showing now?
oh, it flashed for a moment. Right now we're seeing the full the 15 slides or so. So I might want to click it one more time.
I'm in slideshow mode right now, so at least that's what I'm seeing. You're not seeing that?
Yeah, so we're still seeing the 15 slides view. Maybe stop and start your sharing one more time if you could. Thank you.
Okay. That's interesting. How about now?
Perfect. Now we see your main slide. Thank you so much.
Okay, good. So again, today we'll be talking about the ongoing threat and challenges of antimicrobial resistance. The topics that I plan to cover, first I describe the nature and scope and the pathogens involved in AMR, touch on the agricultural issues associated with antimicrobial resistance, which are not inconsequential. Talk about antibiotic drug development and the issues and problems and dilemmas associated with that. The incentive programs that are being advocated now to try to support further antibiotic drug development, and the Pasteur Act, which will still is wallowing in the U.S. Congress, unfortunately. And then finally, to bring it home to the audience, we'll talk about healthcare associated infections, how it impacts healthcare workers, and how healthcare workers can impact the fight against antibiotic resistant organisms, specifically in the realms of antibiotic stewardship and infection control and prevention. And time permitting, we'll have questions. So, what is antimicrobial resistance, or AMR? This is an AI-generated quote, and I only had to tweak one word. But antimicrobial resistance is when microorganisms, including bacteria, viruses, and fungi, no longer respond to medicines used. So antimicrobial resistance, again, is a broad umbrella of various microorganisms. Today we'll be mostly focusing on antibacterial resistance and the pathogens that are most relevant to people and in the healthcare setting. So infections due to bacterial resistance to most or all available antibiotics are increasing worldwide. New antibiotic drug development has been lagging behind this rapidly emerging public health threat, and a WHO report on global surveillance in 2014 stated the problem is so serious that it threatens the achievement of modern medicine. The post-antibiotic era, in which common infections and minor injuries can kill, is a very real possibility for the 21st century. It's 2014. This slide actually is from a talk I gave in about 2016 or 17. And unfortunately, it doesn't need to be edited for 2025. The threats remain, the problems continue, and the threats are real moving forward. So the global burden of antibacterial resistance has been recently reported. At least 1.27 million deaths per year are directly attributable to AMR, according to a report from Lancet published in 2022. And the estimated cost in the US for AMR-associated infections is approximately $4.6 billion annually. So to put it in a little bit of context, here you see the microbial resistance directly attributable. This is the 1.27 million deaths. It exceeds those due to HIV/AIDS or malaria. And then the larger bar is associated antimicrobial resistance, meaning cases where it wasn't direct, but patients might have died from something, renal failure, heart attack, whatever, but they had an antimicrobial resistant infection at the time of their death. So antimicrobial resistance is being looked at utilizing a One Health approach. It's needed to combat AMR because of the various spheres in which antimicrobial resistance exists. So clearly people are impacted by it in clinical medicine, but there is environmental and animal husbandry issues that are deeply impact the overall antimicrobial resistance problem. So this is a busy slide. It's in the context of antifungal resistance, but it's equally applicable to bacterial infections. The inner circle are the various factors that can and do drive antimicrobial resistance: drug use, antimicrobial use and overuse, abuse, climate change, we're not going to talk directly about, but that is impacting infectious diseases in general worldwide, as well as resistant organisms. Agricultural practices. Globalization is an important factor because things spread worldwide very quickly in the 21st century. More recent experience with COVID, demonstrated that, but even it's a slower moving pandemic of antimicrobial resistance, but it does reach countries throughout the world. The outer circles then represent areas that are needed to provide this integrated approach to controlling and managing and reducing the impact of antimicrobial resistant infections. So these infections threaten modern medicine. These are various areas. You can see the numbers of patients who are all at risk for developing an antimicrobial resistant infection. We talked about the 1.27 million deaths per year, but this was more striking to me from a paper last year by the Infectious Diseases Society of America. Every 15 minutes, a person in the United States dies from an infection resistant to treatment with existing antimicrobial drugs. This really hits home. You throw around figures like millions. It's hard to wrap your head around that. But if you think that every 15 minutes, someone in the U.S. has died of an antimicrobial resistant infection, the consequences are staggering. And again, it impacts. The potential is there to impact people who fall in all these other buckets that you see on the slide. So let's introduce the players who are driving resistance for the most part. Enterobacteriaceae is a family of gram-negative bacteria, including E. coli, Salmonella, Shigella, Klebsiella, Enterobacter, and others. The impacts that they have are the antibiotic resistances they've developed. So carbapenem resistance. Carbapenems are one of the newer classes of antibiotic drugs that have evolved in the last 20 or so years. They're often a last resort to use when the older standard drugs aren't available, but now resistance has developed, and carbapenem-resistant Enterobacteriaceae do exist, and they're resistant to nearly all the antibiotics we have currently available. Also on the list are extended spectrum beta-lactamase producers. Beta-lactam antibiotics include penicillins and cephalosporins, which are one of the most commonly used antibiotics in the hospital. And again, when resistance develops, infections, deaths, and costs can be significant. Pseudomonas aeruginosa is a virulent pathogen to begin with, and it has also developed resistances to many of the standard drugs, making it even a greater threat to people and hospitals. And finally, the multi-drug resistant Acinetobacter has been shown to have resistances to many, most, or all antibiotics available, and this can be a deadly threat as well. So those are the gram-negatives. On the gram-positive side, we have methicillin-resistant Staph aureus, which I'm sure you are familiar with. It's one of the most common causes of healthcare-associated infections. And vancomycin-resistant Enterococcus is another problem we're seeing more and more in the hospital. So those are the players. The impact of resistant infections are shown here. There's the risk of death with a resistant bacteria is 1.5 to 2 times that of its antibiotic susceptible counterparts. It's not that these drugs are necessarily more virulent. It's that there's fewer treatment options, and treatment can be delayed if they start with the standard cephalosporins or fluoroquinolones or carbapenem treatment, and then only in day 2 or 3 or 4 get a susceptibility report indicating its resistance to the treatment they've been receiving. Delay in effective treatment is a significant contributor to mortality and sepsis and other severe infections. I liken this to a hockey team that's on a power play. So if the other team has two players in the penalty box, the power play team, it's not that the hockey players suddenly got better at scoring goals, but they're just playing in an environment where it's easier for them to score goals. Similarly, these drug-resistant bacteria, if they're not being treated with effective antibiotics, they're going to have their way with the patients, sadly. So the drivers of antimicrobial resistance are listed here. Inappropriate antibiotic use, including overuse and misuse, which can include taking antibiotics for the wrong reasons, e.g. viral infections. I'm sure you've heard campaigns informing healthcare providers and patients, don't ask for an antibiotic. It's just the common cold. An antibiotic's not going to help. You're going to get better. Not finishing the prescribed course. Partial treatment can leave the pathogen behind, sort of wounded but not killed, and that can be a trigger once it's been exposed to an antibiotic for resistant strains to emerge. And finally, excessive use of broad spectrum antibiotics, which not only treat the pathogen at hand, but also much of the normal flora that inhabits our GI tracts. You've heard of microbiomes in the news lately, not lately, in the last 10 years or so. A lot of work understanding the impact of good bacteria in our gut, and broad spectrum antibiotics can negatively impact that as well. We'll be talking about antibiotic use in agriculture and also the lack of new antibiotics and the challenges in antibiotic drug development. So a little bit of microbiology, apologies in advance for that. But how does antibiotic resistance develop? In the top box, this shows a sort of a one-dimensional view of it. If you have a population of bacteria living in a petri dish or in a bladder for urinary tract infection, most of the organisms are susceptible, and when they're treated with an antibiotic, they will die. But there can be, just through random mutation, a few organisms that are resistant. The red dots indicate. So once you killed off all the susceptible organisms, all you have left are the ones that have not been killed by that antibiotic. So you've easily generated a resistant bacterial population. The second panel is really more on the microbiome sense. If you think about just a normal healthy population along with the pathogenic strain, if you wipe out that population, it creates a vacuum. Nature abhors a vacuum. So any surviving resistant bacteria can and fill that gap without competition from susceptible organisms. The pace of mutations developing are shown here. Bacteria double in size. The bacterial population doubles in size every 20 to 60 minutes, and mutation rates involving base pairs, the famous double helix of DNA made up of the rungs. If you change a color here, that's a mutation. Many mutations may be either lethal to the bacteria or maybe not affected in any way in its ongoing lifespan, or it could be one that codes for resistance to existing bacteria. Again, when you start treating with antibiotics, suddenly that becomes a survival advantage. It's very Darwinian. Natural selection will allow that resistant bacterial strain to survive. Alexander Fleming, as you know, was the discoverer of penicillin, which is a breakthrough in modern medicine, needless to say. But he foresaw the potential problem with antibiotic resistance. In his quote here, penicillin should only be used if there's a properly diagnosed reason. It needs to be used with the highest possible dose for the shortest time necessary. Otherwise, antibiotic resistance will develop. So he's the father of penicillin. He essentially is the father of antibiotic stewardship at the same time. And sadly, his predictions came to pass. Here you see a timeline of various antibiotics, not all, but times when these antibiotics became available commercially and clinically. And looking at Alexander Fleming's penicillin, he was exactly right. Introduced in the early 1940s, PRSA is penicillin-resistant Staph aureus. Penicillin had very good activity initially against streptococci and staphylococci species. It still is effective against strep throats, etc., pneumococcus. But Staph aureus, once it was exposed to penicillin, quickly developed resistance to that drug. Then you have to fast forward to methicillin in the early 60s. That was a semi-synthetic penicillin that had activity against Staph aureus. Still does, and there are methicillin-sensitive strains, but not long after the introduction of methicillin, we started seeing MRSA, methicillin-resistant Staph aureus strains, and these continue to this day. And as we move farther along the timeline, in the 90s and 2000s, we see various resistant genes. The initials aren't necessarily relevant, but they code for resistance to various antibiotics that have been developed. In red for gram-negative rods, in blue is gram-positives, VRE, vancomycin-resistant enterococcus, VRSA, fortunately, vancomycin-resistant Staph aureus. Vanco is the primary treatment drug of choice for MRSA. VRSA has been described, but has really not gained a toehold, fortunately, because that would be a much more difficult infection to treat. So efforts to reduce antibiotic resistance have been working. This is data in the late teens that showed reductions in both antibiotic-resistant deaths and deaths in hospital, as well as incidences of infections due to the various resistant pathogens that we've described before. So about a 30% reduction in deaths and 18% reductions in overall resistance during this period of time. So this is good news. It shows that efforts to try to stem the tide, can work and had been working. But it's that was then, this is now, and the now is post-COVID. So during the COVID pandemic, there were more resistant infections, increased antibiotic use, and less data available and preventive actions to be taken. We all remember the COVID pandemic. It was all hands on deck to treat the COVID patients. Patients were sick. They had respiratory failure, bilateral pneumonia. consistent with COVID, but you didn't want to miss the potential for secondary bacterial infection. So there's a lot of antibiotics used in the ICUs in these COVID patients. And healthcare providers, everyone was, drafted to provide care for the COVID patients. So this impacted infection control and prevention's ability to, do their surveillance and again, the preventive actions, when you're being slammed with critically ill patients, you don't have the time to follow appropriate infection control techniques all the time. And what they found was that with the 6 common antibiotic-resistant organisms we had talked about, there's a 20% increase during the pandemic, peaking in 2021, but it's been maintained into 2022 at the above the pre-pandemic levels. So we still have catching up to do to the progress that we were able to make back in the teens. And as mentioned before, $4.6 billion annually is the cost for caring for these patients with infections due to these antibacterial-resistant organisms. So let's switch gears now and move into the agricultural arena. This is a seminal paper in 1976 where they gave tetracycline supplemented feed to chickens. Within 1 week, the chicken's intestinal flora contain almost entirely tetracycline-resistant organism. Again, it gets back to the schematic I showed. This validates that concept. In the presence of an antibiotic, bacteria will learn to develop resistance to it. They also cultured not only the chickens, but farm workers, and they had increased numbers of resistant intestinal organisms, although it took about 5 to 6 months to appear. But their fecal samples contain over 80% tetracycline resistance in 31% of the samples obtained. Compared to control neighboring farm workers where the single-digit tetracycline resistance was prevalent. So they concluded that demonstrates that antibiotic supplemented feed is a factor in animal husbandry, and this needs to be reevaluated in this form of widespread treatment of animals. Again, 1976, where are we now? Well, we haven't really made much of a dent. These are data from the late teens, 2017, 2018, that showed human consumption of antibiotics only accounts for a little over 1/3 of the total antibiotic consumption in this country. 2/3 are given to livestock, cattle, swine. The other three segments are turkeys, chickens, and other. So we've not made much of a dent in this, and there's a lot of antibiotic resistance being driven by this agricultural use. So there was a report that the government came out with in 2017 trying to combat antibiotic resistance. It was in the context they had already banned antibiotics as growth promoters. That was a very prevalent practice, using antibiotics just to enhance growth, not for infection. But antibiotics were still being used as prophylaxis, in these large livestock farms. A disease could be introduced and could spread quickly throughout the herds. So preventive antibiotics, prophylaxis essentially, was being used. These recommendations were to not use antibiotics for those use. Veterinary oversight of antibiotic use, because a lot of antibiotic feeds were available over the counter back 10 years ago. And they also wanted to enhance surveillance of antibiotic use in food animal production. So again, 2017, this report came out. How did it work? Well, it worked really well at the beginning. There was about a 30% drop in medically important antimicrobial drugs. Medically important means the same drugs are being used in the hospitals to treat patients as are being fed to the animals. So a 30% drop in 2017, 2018, But unfortunately, that apparently was just low-hanging fruit, because now we've plateaued, still at a pretty substantial level of antibiotic use in livestock. And the last thing I want to talk about in agriculture is, this is a cautionary tale. Again, 2015, there was emergence in China of a colistin-resistant gene in animals and human beings. Colistin was an old antibiotic, had coverage of gram-negative rods, including E. coli, and it really wasn't much used because it had a pretty significant toxicity profile. But with the emergence of multiple drug-resistant gram-negatives, colistin was having more and more usage. And now that last line of defense looks like it was being breached. So the first report came from China, but within 6 months, there were reports of the same gene being found in countries throughout the world, both in humans, farm animals, in food, and in the environment. But there actually is a silver lining to all of this. Because it was China and they recognized the problem of colistin positive additives in their feed, they banned its use. So from 2016 to 2018, it dropped to virtually zero. And as a consequence, subsequent screening showed reductions in the prevalence of colistin-resistant E. coli. So the green maps are chickens, the red pink maps are pigs. The darker densities show higher prevalences in 2015, 2016, and the lighter prevalences mean reduction in 2017, 2018. So it shows that moves to remove antibiotics from the livestock can have an impact in reductions in resistant organisms. We just have to, be better at effecting these kinds of changes moving forward. So what can we do as consumers? Try to get products that do not contain antibiotics. This is refrigerated this weekend. So if you look for no antibiotics being used, that's a better selection. This one was interesting because they said they don't talk about no antibiotics, but they talked about being used without hormones or growth promoters. Does that mean antibiotics? I'm not 100% sure. But if you're in doubt, organic foods do not contain antibiotics. That's a hard and fast criteria to be labeled organic. And finally, if you're vegan, there is a problem. You don't have to worry about the meat products, but there is a problem with agricultural use of antifungal pesticides. So sorry about that. We just don't have time to delve into that, but it's a parallel problem for resistant fungi being selected for. So let's move on to antibiotic drug development. This is a schematic of the drug development process. Lots of chemical entities in the lab that are studied for various potential uses. They test specifically for antibiotics. You test against bacteria in petri dishes, then they test them in mice or other animal models to see if it has impact. Then they move into human studies, the phase 1, 2, and 3 studies. Phase 1 and 2 are smaller kind of safety studies, proof of concept for efficacy. Phase 3 is the large registrational study. And if those go well, you can get FDA approval. But the number of drugs that reach FDA approval is way smaller than the ones that, start out in the discovery process. But FDA approval is not the end of the road. There's the commercialization step. And the problem with antibiotics is that they are associated with low sales, high operating expense. There could be post-approval requirements that the FDA may impose on any drug that they approve. But most importantly is inadequate reimbursement in the hospital. If you think about it, an antibiotic needs to be used, like Alexander Fleming said, needs to be used for a finite period of time. So the cost, the revenue that would be generated by a course of antibiotics is infinitesimal compared to, a drug like the GLP-1 drugs for obesity, where they're used on an ongoing basis and can produce millions or billions of dollars. So there's a disincentive to do antibiotic research and drug development. There's actually in the late teens, a company developed a new cephalosporin, and it brought it to market, which was great, but then they had to declare bankruptcy because the revenues they generated just were unsustainable for them. So there's moves to support antibiotic development on both the early side and the late side. They're called push and pull incentives. This actually gives the context of where we are in the antibiotic pipeline. In this period, published in 2022, only 76 antibacterial agents were in drug development. Half of them were against the WHO priority pathogens, but that included mycobacteria, tuberculosis, Clostridium difficile, as well as the other bacterial pathogens that we're talking about. Only 7 late-stage drugs approved for products against those highly resistant bacteria. And by comparison, there are 1,300 drugs in development for cancer in 2020. So antibiotics development is clearly the poor stepchild in this process. So the response to the problem, again, on a plus side, this was just reported a couple weeks ago. A consortium of Novo Nordisk Foundation, the Wellcome Trust in the UK, and the Gates Foundation have launched a new initiative for gram-negative antibiotic discovery. And the purpose is to drive early drug discovery for gram-negative pathogens. That was the left-hand side of the graphic that we just saw, where they can identify molecules that may have potential against the Enterobacteriaceae, Klebsiella, et cetera. So that's considered a push incentive. On the pull side is financial support for products who have brought an antibiotic to the market and to the hospitals. A subscription program was just initiated in the UK, first health system in the world to do this. It's a model that pays companies a fixed annual fee for the antibiotics that they have are being used primarily in the healthcare system. Value based on activity against pathogens on the WHO priority list. And the subscription approach means a fixed amount is paid. So it's a revenue generation guarantee for the drug manufacturers, and can go a long way in terms of supporting their ongoing viability and the availability of these drugs. So this just shows the numbers that can be awarded depending on the degree of breakthrough that an antimicrobial may have, but anywhere from 5 to 20 million pounds per year to a drug company, to a small drug company, that could be a significant difference maker for their long-term survival. So where are we in the US? You may have heard of the Pasteur Act. It's an acronym, sort of a tortured acronym. Sorry, I can't see it because my audio thing. Anyway, it's a bipartisan bill, both in the House and Senate. Unfortunately, it's been brought to the last 3 Congresses and never made it out of committee. It's got broad support by healthcare provider organizations, public health organizations, et cetera. And it's a innovative model, again, a subscription model like we just saw in the UK, where they will pay both for drug development to support the pipeline, as well as reimbursement in order to maintain those drugs available in the clinics. And again, decoupling the antibiotic use from volume used, meaning, how any prescription duration does not impact the amounts you receive in a reimbursement. So again, it failed to make it through the previous Congresses, unclear, along with many other things that are unclear in the current Congress. But with bilateral support, hopefully they'll be able to tweak enough of the details that they can generate more co-sponsorship and eventually, bring this act to fruition. So finally, let's move into the healthcare arena and talk about healthcare-associated infections. Why is antimicrobial resistance considered a healthcare-associated infection? It's because resistant bacteria can emerge from improper antibiotic usage and can spread within the healthcare settings as a result of breakdowns in infection control practices. So the healthcare worker is in the center of all of this. I tried to do a literature search on how healthcare workers, may acquire antimicrobial resistant organisms, and found exactly one paper in the Spanish literature, of all places, in a southern Italy hospital. But it was an interesting study. They took environmental samples and samples of healthcare workers' hands and looked for various organisms. You can see the list that they isolated out of the 3,700 samples obtained, about half and half between environment and healthcare workers. They had 16% positivity, 608 were positive, and antimicrobial resistance was noted in a third of them. The environmental surfaces were a little more heavily contaminated, almost over a quarter. Fortunately, healthcare workers, it was a much more rare event, just over 5%. But any carriage in a healthcare worker, even if it's transient, of these virulent pathogens is a problem, because healthcare workers can be a vector spreading these organisms from patient to patient or environment to patient. So this is, again, a cautionary tale of what the threat is like out there. This is a very impressive picture of where environmental contamination occurs in a standard hospital setting. They used vancomycin-resistant Enterococcus as the organism that they were looking for. They found it in all the green X's. Should have been red X's in my view, but that's okay. But it shows that anything and everything in and around the patient's bedside, can be contaminated with VRE, which is a significant nosocomial or healthcare-associated pathogen. It reminds me of a famous quote. I can't remember who said it, but one of the pioneers in infection control and prevention back in the 60s and 70s, who described the hospital setting as being covered in a fine film of feces. Enterococci live in the GI tract in people. So in order to get onto the environment, it came from the GI tract, from the intestines. So this should be motivation to wash your hands every time you're in contact with anything in and around the patient. So controlling HAI or controlling AMR in the healthcare setting involves infection control and prevention first and foremost. Hand hygiene should be done properly and done often. Adhering to appropriate transmission-based isolation precautions. These organisms primarily would involve contact precautions, gowning, gloving where need be, and again, hand washing before and after each contact with the patient or anything around the patient. Proper availability and use of personal protection equipment, PPE. Environmental cleaning and disinfection is key, as the last slide clearly indicated. These are the unsung heroes in my view. in the hospital. The housekeepers who go in, clean the rooms every day, clean the rooms after a patient is discharged before the next patient comes in. They can be a key element in breaking the chain of transmission of these highly resistant organisms. And finally, education for the patient, the family, and caregivers. Everybody needs to understand the threat and the importance of proper techniques and hand washing, hand hygiene in order to break the chain so that they don't get infected or that it doesn't spread any farther. Finally, antibiotic stewardship is another key, again, foreshadowed by Alexander Fleming. Antibiotic stewardship is now a required program in acute care hospitals. I believe that accreditation, Medicare reimbursement, both require a functioning antibiotic stewardship program. Typical stewardship programs, it's multidisciplinary, an ID doc, an ID pharmacist, microbiology lab, and administrative buy-in to support all of this. Antibiotic usage is guided based on surveillance data on your local healthcare facility and the pathogens that you're seeing. So knowing what has been isolated, knowing what the trends are in terms of antibiotic susceptibility versus resistance is important in making evidence-based, information-based decisions and recommendations on what antibiotics to use, both initially in the empirical setting, because until you get a culture and susceptibility report back, which can take 2 or 3 days, you want to make sure that patient is on an antibiotic that is actually treating what they're ultimately proven to have. But other factors in antibiotic usage is controlling the dose, proper dosage, proper durations, use enough to treat the infections, but don't use any more, and consolidating broad spectrum combination treatments, which are common when the patient first presents with sepsis syndrome or just severe infection. You know that they're infected, you just don't know what the pathogen might be, so you have to cover all the bases. And finally, switching from IV to oral routes has cost considerations, cost containments, and allows for getting the patient out of the hospital in many instances. So this is an interesting depiction from actually from a behavior psychologist approach. It's a little busy, but I just want you to focus on the 2 graphs. This is from the National Healthcare Safety Network that the CDC manages, looking at healthcare-associated infections due to resistant organisms. So the left panel is extended spectrum beta-lactamase phenotypes of E. coli and Klebsiella. The extended spectrum beta-lactamase is, again, penicillins and cephalosporins. On the right is E. coli and Klebsiella associated with carbapenem resistance. Again, the carbapenem is one of the newer agents introduced. And the reason that I interpret this going down, and the paper reported that the data suggests early aggressive response is outlined in the CRE-specific patients, can slow the emergence and even decrease the emergence from resistant pathogens. But so why did the CREs, why were they handled more effectively? It's because I think it was associated with many more levels of red flag. These were the super bugs at the time. Yes, extended spectrum beta-lactamases, okay, yes, it's a problem. We need to, wash our hands better, look at infection control and prevention practices. The CREs, really were red lights. And I think the healthcare staff responded more aggressively in order to try to deal with it, and they did, as the details show. So again, there's potential for bringing these infections under control in the healthcare setting. Last thing I want to note is diagnostic stewardship. This is from the infectious disease meetings last fall. As I had mentioned, culture and sensitivity, we're still using 150-year-old techniques, plate it out on a petri dish or a culture tube, isolate the organism, run a panel of antibiotic susceptibilities. That'll take 24 to 48 to 72 hours. This is an automatic sequencer looking at whole bloods. This would be diagnosing bacteremia, where they use whole genome sequencing to identify a variety of pathogens. ESCAPE is an acronym for Enterobacter and Enterococcus, or the E's. The K is Klebsiella, S is Staph aureus, A is Acinetobacter, P is Pseudomonas. So they identify, and AR is antibiotic resistance. So they can test for the identity of the organism based on the genetic sequencing, and they can identify genes that indicate antimicrobial resistance. And you can get this turnaround in it's a few hours, I believe. I think it's less than a day compared to, again, 2 to 3 days with standard techniques. So this will get important information to the clinicians quicker and allow for more appropriate and targeted and tailored antibiotic usage. So to sum up, the future is now for combating AMR. We need to be involved in all of these arenas. Stewardship involves the judicious use of current and future antibiotics, as well as decreasing the agricultural use of antimicrobials. Innovation, microbiological diagnostics, as I just have shown, as well as innovative means to incentivize further antibiotic drug development. And then finally, healthcare workers are key in the healthcare setting, involved in the infection control and prevention that I had mentioned, to break the chain of emerging resistant pathogens and spread of those pathogens across the hospital wards. So lastly, I want to leave you with the idea of advocating. Appreciate your attention. This is how to communicate the issue of antimicrobial resistance. You're now officially deputized into the fight. And to be honest, this is the format I followed. The Wellcome Trust came up with these bullet points to how to explain most effectively. We talked about how antibiotic resistance undermines modern medicine. We need to explain that succinctly. And it is a universal issue, but it's one that's here and now, and there's things we can do here and now to make an impact. It might be small impacts, but they all add up. So that's what I have. I thank you very much, and open to questions.
Thanks so much. What a terrific presentation. And it's so packed with such crucial information to be shared with the public in general, but certainly the audience today has an occupational health perspective. And so hopefully we can get it to the public at large. There were a few questions, but of course you answered a lot of these questions already. And so let me just throw out some questions here. Since I am focused on the workplace, and the workplace can be hospitals, can be healthcare organizations, and so on, but it can also include just your normal employee in retail and in high tech, whatever. So one of the vectors that you called out were healthcare workers. The transmission process, is it by physical contact or is it aerialized? Is it in the air? If we want to avoid AMR and we go to work every day let's leave hospital settings aside, what's your prognosis for, how well or how sick people are going to get going to work?
Yes, it's primarily, so the data I showed about environmental contamination and healthcare workers' carriage on their hands, that's all contact, direct contact. So these organisms are not wafting into the air by and large. So it lands on the environmental surfaces from healthcare workers' hands, or you pull the sheets back, you throw them on across the the dining table or the tray table across the bed. I mean, it's from touching one surface to the next surface, and that surface can then become the next patient in that room or across the hall. So that's by and large, the primary focus. Now, if you have a resistant infection in someone with pneumonia, so could they be aerosolizing or droplet spread when they cough? Yes, that's a possibility. That's why you have to you have the isolation recommendations from infection control based on individual patients, not only the organism, but where the infection might sit. But the chain of events is, again, from a patient to an environmental surface, to a healthcare worker's hands, to another patient, into their GI tract, and then from there it can, wind up in their urinary tract, or when you put in the catheter, a urinary catheter, as an example. From a healthcare worker's risk perspective, I was actually encouraged. That's the first thing I Googled when I, knowing the audience, and what are the risks to them, and it appears to be low based on the lack of literature associated with it. There was one paper that I didn't have time to include. It was in Australia in a cystic fibrosis clinic, and they looked at their healthcare workers' risks for Pseudomonas and MRSA, and found that their healthcare workers with cystic fibrosis did experience a higher risk of hospitalizations. So, if you're a healthcare worker with underlying conditions, you'd want to be extra careful, yes. But even, healthy healthcare workers, it's a threat that you could be carrying these. And again, another slide I didn't show is if there's infamous ones of take fluorescent dye, you put it in a swab on a patient's nose, and an hour later take a scan of them, and their whole body lights up. Everything around their face, their hands, their coats, everything. So the organisms are invisible to the naked eye, but they are there, and hands are the primary vector.
Right. And so it sounds like cleaning routines are going to be very important,
Yes.
As you say, with environmental contact. And what are the agents that are most effective against AMR?
Well, the agents are effective against the microorganisms. The resistant organisms are resistant to an antibiotic, but we're not using an antibiotic to clean them from a surface. So bleach, quaternary ammonium products, which are standard recommended disinfecting agents. Disinfection is the appropriate term. You're not sterilizing like surgical instruments, but disinfection is reducing the contamination level to like less than 1% of what it started out as. So there are effective products that are used in the hospitals, and it's just a matter of using them appropriately, not just doing a quick one wipe against the cloth. You want to kind of make sure you do some scrubbing and have some contact time for the organism to be impacted.
So really, one of the keys here to reducing the problem is to not get infected to start with. And so we have protocols for doing that if we would only follow them. Did you want to show your slide, the poster slide? That's your takeaway?
Sure.
And we have just a minute to go.
Yeah. Where's my share button? Here we are. Okay. Yeah, this was a poster from the CDC. Can you see that? It's too wordy to walk through it, but if people want to take a screenshot or look up the reference on the CDC website, it'll pop up. But it really shows the important areas to control the organisms themselves, improve antibiotic prescribing, and again, awareness, and if you see something, say something kind of thing. And again, I can't overemphasize the importance of hand hygiene and hand washing. There are proper ways to wash your hands, and it's not just a cursory, thing, to talk about, 20 or 30 seconds and, good scrubbing, all the crevices, between your fingers, under your nails, et cetera, et cetera. And or soap and water is important if your hands are visibly soiled with any secretions from the patients. But the hand sanitizers are also effective in reducing, if you just happen to pick up some bacteria from casual contact with these surfaces we talked about, hand sanitization is also effective.
That's helpful. Okay, we've come to the end and we thank you so much. And I apologize to all of you who have put in questions. Hopefully you got them answered in the process of the presentation. But what wonderful advice, and let's hope Congress takes action on the bills that you're trying to put forward. So thank you so much.
Thank you, and you're welcome. Thank you all.